and welcome back to the channel. I hope that everybody is doing well today. If you are new here, then hi, my name is Brittany. I am a nurse practitioner, and everything on this channel is dedicated either to nursing content or nurse practitioner content. And today I'm going to be talking all about RSV. It seems to be a very appropriate time to talk about this virus because it is that time of year where viruses like RSV are much more prevalent. But before we get into today's topic, I did want to say a couple of things. If you don't know, I am the creator of the Brittany Holzbeck NP review, and my entire AANP and ANCC review course are available on my Patreon. I just received accreditation through the AANP, so you can actually collect continuing education credits if you complete the course. I also have a $5 tier over there, which is all new NP clinical pearls, so everything for those new nurse practitioners that are just entering into practice. So definitely go ahead and check that out. And then I also just started a separate channel here on YouTube called Brittany Vlogs, where I don't do any educational content. I just have a little bit more of a open, free platform where I get to be a little bit more creative and share some of my day-to-day life. So everything that I just mentioned will be linked in the description box below if you want to come and check me out. But otherwise, let's just get into today's content and talk all about RSV. All right, so first let's just go over a little background of RSV, or respiratory syncytial virus. So RSV causes an acute respiratory infection in virtually all people. However, depending on age and their comorbidities, some individuals do become more ill than others. So RSV is the most common cause of lower respiratory infections, specifically bronchiolitis, in children less than 1 year of age. Hospitalization rates due to RSV is the highest among infected children less than 5 years of age, and especially in those children less than 6 months old. Generally, if children over 5 years of age require hospitalization due to RSV, they typically have some sort of underlying health problems, so such as asthma or if they are immunocompromised. Another at-risk population with RSV are those adults that are 50 years of age and older, and specifically adults with either chronic heart or lung disease. So transmission of RSV, this is primarily done through direct contact of virus-containing secretions. However, droplet aerosols are also believed to be involved in the spread of this virus. The virus is found to survive for several hours on both hand and surfaces, so hand hygiene is of the utmost importance when trying to prevent the spread of this virus. The incubation period for RSV, this is generally 4 to 6 days. And remember, the incubation period, this means that the time from when a person is first exposed to the pathogen to when the first symptoms appear. And unfortunately, even though almost all persons are infected with RSV by the time they are 2 years of age, previous infection does not seem to protect against reinfection, though it does appear that reinfection with RSV does involve more mild symptoms. All right, so next up, let's talk about RSV symptoms. So symptoms of RSV in children less than 2 years of age typically present with lower respiratory illness, often being bronchiolitis. So bronchiolitis, this is broadly described as a clinical syndrome of respiratory distress occurring in children less than 2 years old. It does, however, generally begin with upper respiratory symptoms, and then it progresses to lower respiratory disease, and this is when we typically will see these patients. So symptoms of lower respiratory disease include wheezing or crackles. Occasionally, symptoms can even progress to acute respiratory failure. And then also for infants that are less than 2 months old, occasionally the presenting symptom for RSV is apnea, and that's a pause in the child's breathing. And this has actually been associated with SIDS. And so it's obviously very important that we're keeping out for any signs of respiratory distress or episodes of apnea in our young children. So typically a person's worst case of RSV infection is their primary infection, or this is their first illness with the virus. And then the illness severity generally does decrease after the third infection with RSV. In older children and adults, RSV typically causes more upper respiratory symptoms. So again, this includes things like cough, nasal congestion, and conjunctivitis. Wheezing can also occur, though, in these populations as well. About 35% of older adults with RSV will experience wheezing. And then 2, lower respiratory tract involvement can occur as well. So this can involve into things such as like bronchitis, pneumonia. It can also progress to an exacerbation of any chronic airway diseases that these patients have. So they can have an exacerbation of their asthma or even COPD. And then RSV in adults that are 65 and older, or those who are immunocompromised, those patients, they tend to have more complications. So things like increased length of hospital stays, again, exacerbations of any chronic respiratory diseases like COPD, and even higher mortality rates. Very specifically, individuals that are hematopoietic cell transplant recipients, these patients have a very poor prognosis with RSV. There's an approximate 70% risk of mortality associated with RSV in this specific population. All right, so moving on to diagnosis. So a diagnosis of RSV should be suspected in infants and young children if they present with wheezing during times when RSV is known to be circulating locally. It's important to note that RSV typically causes seasonal outbreaks. So in the northern hemisphere, RSV outbreaks typically occur from October or November all the way through April or May, and they peak in January or February. And then in the southern hemisphere, RSV outbreaks occur from May to September, and they peak in the months of May, June, or July. So a diagnosis of RSV should be suspected in older children or adults if their lower respiratory infection requires hospitalization. However, a diagnosis can be confirmed with lab testing. Generally, we use the polymerase chain reaction or PCR testing. Also, rapid antigen testing is available, though it's slightly less sensitive, so that means it's possible to receive a false negative. Typically, though, diagnostic testing is not required with RSV unless it's going to affect your treatment plan. So, for example, if you're considering antibiotics and you want to rule out RSV first, then diagnostic testing can be helpful. Or if the patient is hospitalized, then they definitely will do testing there as well. All right, so next up, let's talk about treatment. So treatment for RSV infection, it's individualized, it's primarily supportive. So this means we're monitoring their vital signs, maintaining hydration, offering respiratory support if it's needed. Occasionally, it can advance so far as to needing mechanical ventilation, specifically, obviously, if those patients are experiencing severe respiratory distress or severe apnea. But generally, it's more of just monitoring their symptoms, making sure they're staying hydrated, and keeping an eye on their respiratory efforts. So for infants and children with bronchiolitis, treatment does depend on the severity of their disease. So it's really important to be familiar with indications for hospitalization with these patients. So indications for hospitalization with children that have bronchiolitis would be symptoms of toxic appearance. So if they're just appearing very, very unwell, like lethargic, if they're having moderate to severe respiratory distress, again, if they're having episodes of apnea or hypoxia, if they're having poor feeding or dehydration, or if it's believed that the caregivers are unable to properly care for the child at home. And so in order to determine if a child has that moderate to severe respiratory distress that we just mentioned would be an indication for hospitalization, we can actually use something referred to as the respiratory severity score. And so we'll take a peek at this now. There's a lovely table here. I modified it a bit, but I took this from Up to Date, and so I made sure to give credit on the image here. All right, so here you can see the respiratory severity score graph. And so on the left-hand side, that BPM that you're looking at, it's actually breaths per minute. And so you can see that they can get a certain amount of points for how many breaths per minute they're taking. If it's in yellow, it's 1 point. If it's in orange, it's 2 points. If it's in red, it's 3 points. And then that next little box or group of boxes is looking at their respiratory effort. If it's in green, it's 0 points. Yellow, so that would be mild subcostal or intercostal retractions. That's 1 point. You can read through it, but they can get 2 or 3 points. And then you're looking at breath sounds up at the upper right hand. Again, you can get 0, 1, 2, or 3 points. And then below that is their feeding and their vocalization. Again, they can get 0, 1, 2, 3, or 3 points. And so they can get a total amount of 12 points when using this respiratory severity scoring system. A moderate respiratory distress, that is 5 to 8. So anything 5 or greater indicates moderate respiratory distress and would indicate the need for hospitalization. So just take a minute to look over that. I'm not going to read through every bit of it, but it's a very, very helpful tool when you are assessing a patient, a young child with bronchiolitis, and whether or not they need to be referred to a hospital. An important point to mention with this graph, though, before we move on, is that apnea, you can see that apnea is not included on this graph. And it's important to point out that if the patient is having episodes of apnea, this is an indication for severe disease, and this definitely requires a transfer and an evaluation in the ER. It's, again, it's most commonly seen in preterm infants or infants less than 2 months of age, but it's definitely something that we want to be evaluating for. And if we see episodes of apnea, they need to go to the hospital. All right, and then continuing on with the treatment for RSV. So pharmacological therapy for RSV, it's typically not indicated. Occasionally, inhaled albuterol or epinephrine is used in patients that are having severe respiratory distress and wheezing. So that would most likely be, in a hospital setting, not necessarily in an outpatient setting. But typically, we're not using that. That's only for severe patients. Also, systemic glucocorticoids. Again, this is not routinely recommended. The literature does not routinely recommend using systemic glucocorticoids unless there is a suspicion for, or if there's confirmed underlying airway disease such as asthma, then those patients could possibly benefit from that medication. And then antibiotics. Of course, these are not typically indicated. It's a viral infection unless the patient is 28 days old or younger, or of course if there is a coexisting bacterial infection. And if you are thinking that a 28-day-old infant or younger is needing antibiotics, they also should be sent to the hospital for a complete workup. And then another pharmacological option is the antiviral ribavirin. This could be used in immunocompromised patients that have confirmed RSV infection. This agent, it's either nebulized or it's given orally, and it's shown to have activity against RSV. It's not, however, routinely given to children or infants. It's contraindicated in pregnant women, and it also needs to be avoided in men whose partners are pregnant. Because ribavirin, hopefully I'm saying it correctly, it has a very long half-life. Women that have used this agent, they need to wait 9 months before even getting pregnant after its use. And men who have used the ribavirin, they need to wait 6 months before impregnating a woman after using this medication. And then also there's caution advised with this agent because it has been associated with bronchoconstriction. So we want to be cautious with any patients that have asthma or COPD because we know that that can exacerbate their symptoms. All right, so before completing this discussion, we absolutely should talk about the RSV vaccine. So we've had some amazing new developments in regards to vaccinations against RSV. So in May of 2023, the FDA approved 2 vaccines in the U.S. for adults 60 and older, and these 2 vaccines are listed here. There is the RSV and the Abrivio. Hopefully I'm saying those correctly as well, but you can see those there on the screen. Indications for the RSV vaccine in patients 60 and older. So there's various factors that puts an individual at either an increased risk for infection or an increased risk for severe disease. And these would be indications that we should definitely vaccinate those patients or talk to them about the benefits. So factors including if they reside in a nursing home or assisted care facility, if they have frequent exposure to young children, if they have the presence of cardiopulmonary disease, so that would be COPD, asthma, CHF, coronary artery disease, if they have kidney disease, liver disease, diabetes, chronic or progressive neurologic or neuromuscular disease, if they're immunocompromised, if they have hematologic disorders, if they are frail, if they have advanced age. All of those factors are going to put the patient at an increased risk for either getting the infection or for having severe disease with the infection. However, so all of those are indications, but it is recommended still by the literature that RSV vaccination is given to patients that are 16 older, even without these comorbidities. So it's a discussion that we definitely want to be having with our patients. Even if they don't have these comorbidities, they do have a lower, risk for severe disease or hospitalization. It's still shown to benefit this population. And so it's an important point, again, to just go over with our patients. And then in July of 2023, the FDA approved the monoclonal antibody nirsevimab for the prevention of RSV in newborns and infants, which is also huge. This is such great developments that we're having here. So nirsevimab, this is indicated for infants that are born either during the RSV season or if they're entering their first RSV season, unless the birthing parent received RSV vaccination at least 14 days prior to birth. If that is the case, then the infant doesn't need to get the vaccine because they are protected. Also, nirsevimab, it's indicated for children up to 24 months of age if they are vulnerable to developing severe disease. So currently, this is for current time right now, so January 2024, there is a limited supply of the nirsevimab. So the CDC has made some recommendations as far as administering and who would most benefit from their limited supply. So for infants that are less than 5 kilograms, if they're born before October 2023, then we should be giving them a 50 milligram dose of nirsevimab now, like ASAP. And then if infants are born during October 2023 and throughout the RSV season, we need to administer the 50 milligram dose of nirsevimab within their first week of life. And that's for infants that are less than 5 kilograms. And then for infants weighing 5 kilograms or more, we want to be prioritizing the nirsevimab 100 milligram doses for those infants that are going to be at the highest risk for severe RSV. So that's infants that are less than 6 months of age, American Indian or Alaska Native infants that are less than 8 months of age, and then infants aged 6 to less than 8 months with conditions that make them susceptible to severe RSV disease. So this would include things like prematurity, if they're born before 29 weeks gestation, if they have chronic lung disease, congenital heart disease, if they're severely immunocompromised, if they have cystic fibrosis, neuromuscular disease, or congenital pulmonary complications that would prevent that child from being able to clear secretions on their own. All of those are going to be factors that could make the child have worsening RSV with the development of severe disease, and so we would want to vaccinate those children. And then finally, in August 2023, Abrysvo, this was approved to be given to pregnant women, so between 32 weeks gestation and 36 weeks and 6 days gestation. And this is great because vaccinating the mother this late in pregnancy actually helps, of course, to protect the infant for the first 6 months of their life. And then I should mention that there is another monoclonal antibody, palivizumab. These are tricky to say, but this was actually approved back in 1998. It's the only preventative option we had for severe RSV before development of the nirsevimab. So palivizumab, it's approved in high-risk infants and children less than 24 months of age. However, the dosing is horrible. It actually requires up to 5 IM, so intramuscular injections monthly, and we're only using this agent if nirsevimab is unavailable. We want to first use the nirsevimab. And my child that was just born in November 2023, she actually got to get the vaccine, and I was so happy to help protect her against RSV because it is a horrible disease. All right, well, that is going to complete today's video. Hopefully you found it helpful. If you did, don't forget to like the video and subscribe to the channel. It's a free way to help me out, and I really do appreciate it. And if there is anything that you would like to see me discuss in future videos, go ahead and leave those in the comments below. Otherwise, I wish you guys nothing but the best. Don't forget to learn something new every day, and I will talk to you very soon. Bye.